afternoon, everybody. First of all, thank you, Fever Foundation, for having me here and giving me this opportunity to be presenting this topic. And as a ID physician, whenever I like talking about stopping antimicrobials. So probably that's the reason I chose the topic. And I am sure Dr. Vivekanathan has given a very nice presentation, but let us hear out my viewpoint as well. So today I'll be talking about fever in ICU. Who is not responding to an antibiotic? Will you antifungal without proof? Yes or no? At an outset, I would say no. And individualization, again, as he said as well, is the key. It should not be a blanket statement that everybody who's not responding to fever should be on antifungals at the get-go. And yeah. So somebody wants to add an antifungal empirically to a patient for the given scenario. Now, what are my major, I will take you in next 10, 12 minutes max through whatever evidence I think is adequate for this. So fever in ICU can mean multiple things. There was a talk in the beginning of the session today about hypothermia and pyrexia. Pyrexia, again, there are causes like infectious causes and non-infectious causes. And then there is a long list. Most of the time, non-infectious causes do get, they are not, they get sidelined, particularly, especially in ICU setup. If somebody is presenting with fever, we all, even I, may tend to kind of lean on the side of infective etiology rather than looking at a non-infective etiology. So coming to incidence, this is a study by Dr. Aldana Loke Chakravarti, which my opponent also has showed. See, we are talking about 6.51 cases in 100 ICU admissions. And it included a whole number of 215, 112 patients across 27 ICUs, and 1,400 patients had candidemia proven on cultures. So we are talking about a very small subset of patients. Number one, I understand that there is a very high risk of mortality associated with candidemia, but still we are talking about a very small subset of patients. Now, say let's do a simple math. We have 100 patients admitted in ICU. We know that the temperature detection will be positive, or patient will have fever in approximately 50 patients as per the previous data. And out of this 50 patients, only 25 patients probably will have infective etiology. And out of that infective etiologies, probably as 80 to 90% patients are usually a bacterial infection, and rest of the remaining infections like viral, parasitic, and fungal forms the other subgroup. So we are talking about probably less than 5 patients in our ICU setup. And I again say, I understand the mortality is quite high. See, so this is this is a data from ICMR as per the AMR surveillance network in 2021. It was published. So you see that the total ICU occurrence of Candida infections across all isolates is around 1.1% for Candida tropicalis, 0.7, or less than 1% for all the Candida species. On contrary, for our bacterial subgroup, the occurrence and the percentage at which they occur is quite high. So you can see the 13.1% E. coli. Our sweet Klebsiella keeps always be occurring more than 20% with 20% rate. So there is always a high risk of having a bacterial infection rather than a fungal infection. So now yearly trends of isolates of Candida have not changed much. This is ICMR data from 2021, and it has compared it from 2016 onwards. So you see, for our total Candida isolation, actually it has dropped down from 2016 if you compare. I understand the culture positivity rates are low, and sometimes it may not show a positive culture report as well. But then we rely on colonization index too much that we should even keep this in mind, that actually culture positivity rate is not that much for Candida isolation. So it is not, again, the numbers are lower when compared to the 5 years ago numbers. Now this again is an ICMR data across the country, across almost 20 plus centers, and including north, south, east, west, all zones. So see, we are looking at the overall picture. You can see here, the maximum subgroup of infections are caused by 50% are caused by enterobacterial, 25% probably with your NFGNVs, your Acinetobacter and all. Then the small thin line of 2.5% is the fungal isolates. I understand for blood, it is, you are having a 7.9% of isolates in blood, but then they are being positive in blood and you know that they are okay. So if there is a Candida in blood, it flashes positive as early as within 24 hours, you'll know that there is a yeast growing in blood. We know that, okay, having said that, what I wanted to emphasize that bacterial burden is still more than the fungal burden. And the occurrence of bacterial infection is very much more than the fungal infections. Now we are talking about so what we have, you may say or you may argue that we want to add an antifungal because the patient is not improving on antibiotic. So my argument towards that is actually how many antibiotics that we use as a first line of antibiotics actually work. We have good amount of resistance prevailing across the ICUs, across the different centers. See, the meropenem that we use are somewhere around 70% resistance, and this varies from center to center. Even in ICMR, where they again checked it amongst different centers, the carbapenem resistance in Klebsiella pneumoniae, you can see it is around 60% in OPD, and susceptibility is only 27% for ertapenem and 31% for imipenem in ICU setup. So that indicates that actually we may be wrong in our antibiotic selection. We have to rectify that first rather than correcting the addition of antifungals. Anyways, so we similarly you can see that carbapenem resistance for blood isolates of Acinetobacter is low. Susceptibility is quite low. Meropenem is also quite low again. And these are the trends of dropping susceptibility of several antibiotics which we use for anti-Acinetobacter all through this trend shows from 2016 onwards till 2020. So there is a dropping trend and susceptibilities for all the antibiotics which are generally used. But so what I wanted to make a point is, yes, definitely we have a disease with high mortality, but probably the burden of the disease is quite low, and we still have bacterial infection which occur in more abundance, number one, and are more resistant, number two, and they may not be responsive to the normal antibacterial which we are using. So we have good amount of carbapenem resistance. We have colistin resistance prevailing. We also know that now ceftazidime, avibactam, and astrenal synergies are also resistant. So we may want to first optimize our antibacterial profile before the addition of antifungals. But see, I still want to add, somebody still wants to add an antifungal empirically. So yes, my dear friend said that I will be banking on this trial, but this is not the only trial I'll be stating. Empiricus trial definitely had a low fragility value, but it did state that in a non-neutropenic critically ill patient with multiple candida colonization, multiple organ failure exposure, multiple organ failure, and exposure to broad spectrum antibiotics, there was no significant difference across the different QSOFA groups and across different subgroups with be it surgical category, medical categories, and different colonization index more than 0.5 or less than 0.5, candida score more than 0.3 or less than 3. Even in subset analysis, they failed to show, intent to treat population also, they failed to show any significant difference between the two. You can look at the forest plot. Now, but I'm not banking only on this trial. So see, I'll only talk about RCTs. This is an intense trial, which was done, it is again exploratory, multicenter, randomized, double-blind placebo trial, which did not show any evidence that preemptive or prophylactic therapy administration of echinocandin was effective in in preventing invasive candidiasis. Okay, so this again was difficult. Was another RCT which kind of helped us to state it against the utility of preemptive or prophylactic use. Coming to surgical patient, and the previous study was actually conducted in intra-abdominal surgery, so surgical patients. So the subgroup which we consider at probably the highest, at highest risk, and the drug use was echinocandin here. And this study is fairly recent, it is in 2015. So the subgroup that we consider as the highest subgroup also, they didn't fail to show any major benefit here. Empirically, fluconazole when we were not talking about echinocandins back in before 2010 probably, we were using fluconazole quite often. And empirical use of fluconazole versus placebo, again, it was an RCT, did not show any benefit in, uh, bringing down the mortality of patients. This is another RCT yet again, in which double-blind placebo trial of fluconazole to prevent candida infections in critically ill surgical patients. It failed to show difference in death rate. That was, either in fluconazole group or in the placebo group. So, okay, infectious disease physicians are crazy. They keep talking nonsense. They always come and say that stop this, stop that, don't do this, don't do that. Let us talk about critical care society. So see, the surviving sepsis campaign guidelines, they updated their recent guidelines in 2021. Okay, so in this guideline, what they talked about is they have actually changed their recommendation. They recommended empirical broad spectrum therapy with one or more antimicrobials for patients who were, and they wanted to give antifungal coverage early. In the past guideline, which now they have changed, they suggest some use of antifungal therapy, and in the literature they also say it should be individualized. And this is a weak recommendation, and the quality of evidence is again low. And even in this patient 23, the 22nd point, they also changed this particular guideline. Earlier they were saying that we should cover. Now they are saying that there's no need of addition in a low risk population group. So because what they say clearly is most studies fail to show any demonstrate a causal relationship between antifungal therapy and the outcome. Hence, even the surviving sepsis campaign is not in hurry to add an antifungal when we are dealing with a patient who is probably sick in the ICU. IDSA guideline estimate guidelines, which my colleague quoted. Actually, IDSA guidelines were published in 2016 before the trials came, and even the estimate guidelines were published in 2012. They're quite old guidelines have not been updated. Lazy infectious disease people, but probably they will update it, and when they do, I think the guidelines may change, like surviving sepsis campaign guidelines have. So what is the issue? Why am I saying that we should not probably do this very often? I really am a doctor. I want to save my patients. I want him or her to do well. So I have no problem in doing whatever is in benefit to do that. But we need to keep certain salient points in our mind. See, empirical antifungal treatment may obscure the diagnosis of invasive candida infection in itself. So even if there is some amount of candida which we are suspecting that patient may develop later, if you start the patient on antifungal initially, then the culture definitely won't grow, even if the person develops fungal infection later. It may not influence the development of outcome of invasive disease. Colonization, infection, and all these complications that we are talking about due to candida are actually one of the several life-threatening complications that a critically ill patient develops. So probably it may serve as a marker of severity of primary illness, and consequently impact of antifungal treatment may be limited. We may need to concentrate on primary as well, primary problem of the patient as well. So it in itself alone is not the problem. So it has to be looked at as a whole thing. Now, invasive candidiasis is an uncommon event in the general ICU population, and the number needed to treat to prevent IC is actually very high. So if we need to, suppose we need to treat a lot of patients to prevent one invasive candidiasis patient, that may lead to inadvertent use of antifungals. My colleague persists on adding antifungals, but I said that burden of disease is extremely poor, no evidence to support. But he says, see, we will risk stratify the patient, and then we will go ahead and give. So how much risk is actually a risk? Risk factor for MDRO in ICU and risk factor of invasive candidiasis are so more similar. They're almost same, apart from candida colonization, which in itself might have happened because the patient was on broad spectrum antibiotics, and serum surrogate marker beta-D-glucan. We'll talk about it in the next few slides. See, even if we risk stratify a patient depending upon your candida scores or risk factors that are given in several studies, there are several things that are overlapping. So how will you actually distinguish between MDRO or candidiasis? So we cannot just rely upon something like, a patient has neutropenia, he's on immunosuppression, he's on longer, he can even have an MDRO. We should probably, and that's more common, we should probably optimize our antibiotics first. Okay, I'll use a candida colonization and surrogate.
So Neha, can we summarize, because we may be running short of time?
Slides, yeah. So candida colonization, sepsis occurring in patients with multi-organ dysfunction and multiple sites in patient receiving broad spectrum antibiotic agents. They are really due to invasive fungal infections. These are my references. Your beta-D-glucan are not significantly effective in distinguishing between candidemia and candida colonization. So you may be wrong when you are choosing that as a surrogate marker. So candida score may be as one of the utility factor, but it should not be relied upon completely. Then if, as he said rightly, if we use too much of antifungals, we may drive the fungal resistance. Now we are very hell-bent on using echinocandins. How effective are they? So the occurrences in ICU are commonly ICU occurring candidas are parapsilosis, auris, and they are actually not very much susceptible to echinocandins. You can see the auris probably, this is again a ICMR data, auris probably is more common in ICU setup. And when we add echinocandin, we may be wrong in thinking that we actually are preventing that. So again, bigger class of death is always not better. So we may not be right in addition of echinocandins at the get-go, but we, there's no benefit noted of, increase, no benefit noted for the risk stratification and even use of seromarkers. So let's summarize. This is my last slide. I'm sorry, I had to rush through last few slides. Let's summarize. So not all fevers are infective and common things are still common. So we should probably concentrate on optimization of our antibiotics before switching directly to antifungals. One size does not fit all. Not everybody can be treated as, okay, 3 days antibiotics not responding and we will right now go ahead and add an antifungal because 3 days over, I can't wait. We probably have to individualize for one patient from one patient to another and evaluate if necessary. I understand in ICU setups, there's no time to wait that much, but we should be quick in that. And as soon as possible, we have to do. We have actually murdered all the antibiotics and we can still save antifungals. Even if we start antibiotic for some reason, depending upon the surrogate markers and depending upon the risk factors, we must know when to de-escalate. And as my friend said, that de-escalation may be helped by the surrogate markers. That is one good point about surrogate markers we should utilize. So thank you so much. With that, I'll end.